Thank you for joining us today for our Demystifying Anaphylaxis webinar. I am Jennifer Gertz, Executive Director of Food Allergy Canada. May is Food Allergy Awareness Month, and this year we are running our Know It, Treat It campaign in an effort to raise confidence in treating anaphylaxis. We want to demystify anaphylaxis and empower all Canadians to know what the signs and symptoms are and how to treat it. Today, we have two leading experts on food allergy and anaphylaxis to answer our questions, Dr. Philippe Bégin and Dr. Julia Upton. Before we get started, a couple of housekeeping items. Please note that this session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. Thank you to everyone who submitted questions on registrations. There are some common questions here that we're going to tackle in today's session. If you have additional questions during the webinar, please submit them in the chat box throughout, and we'll try to get to as many of them as we can. This webinar will be recorded and shared on foodallergycanada.ca afterwards. Now let's start with some background on today's session and format. As a parent of children with food allergies, I can attest to the fear of anaphylaxis, especially when it began with the experience of a severe reaction in the first place. The fear is real and anxiety producing, especially when we hear things like each reaction can be very different than the last. Trace amounts trigger anaphylaxis. Reactions become more severe on subsequent exposure, and anaphylaxis is life-threatening. Yet much has been learned over the past decade through anaphylaxis research, increasing use of oral food challenges, and the introduction of oral immunotherapy in allergist practices. Some of these statements of what we've come to know can be challenged. Today's session is about building our understanding of anaphylaxis and empowering us to treat it while getting to the fact or fiction on some of our commonly held beliefs. Today's session is essentially a Q&A format with our experts, and it's going to be broken into 4 sections. From the submitted questions, we will be talking about first anaphylaxis, setting the foundation by defining it, and a discussion around who's at risk. The next section is around signs and symptoms of anaphylaxis. Then we'll move on to treating anaphylaxis. We received a number of questions from the audience around that, sitting in that zone of uncertainty. What do I do here? You know, do I treat, do I not treat with epi? And then we're going to finish off with a fact or fiction section. Now I'd like to introduce our 2 experts, both of whom are also members of Food Allergy Canada's Healthcare Advisory Board. We have Dr. Philippe Bégin. Dr. Bégin is a clinician scientist and assistant professor at the CHUM, that's the University of Montreal Centre Hospital, and Saint-Justine, and teaches allergy and immunology at the University of Montreal. He is a director of a public oral immunotherapy clinic at Saint-Justine. He's also on the board of directors for the Canadian Society of Allergy and Clinical Immunology. We also have Dr. Julia Upton. Dr. Upton is an allergist on staff at the Hospital for Sick Children in the Immunology and Allergy Department, an associate professor in the Department of Pediatrics at the University of Toronto, and she's also the past chair of the Anaphylaxis and Food Allergy section of the Canadian Society of Allergy and Clinical Immunology. I would invite our guests to turn on their webcams and we'll get started. Welcome, Dr. Upton, Dr. Bégin. We're delighted to have you here, and let's dig in. So let's start with the defining anaphylaxis. You know, the common definition that we're operating with today is anaphylaxis is a severe life-threatening reaction. So it's easy to make the connection with fatality. Dr. Bégin, I'd like to start with you to help us understand, you know, is that the right definition? Has that definition evolved? And if you can also set it in the context of, you know, how we define food allergy as well.
Yeah, that's a very good question. And when we're doing presentations for family doctors, sometimes we present all the different definitions of anaphylaxis. There are like 7 out there. So it depends on what you're talking about. So if you're talking about, how to recognize anaphylaxis, you're going to focus on combination of symptoms. So oftentimes people will say that's anaphylaxis, a reaction when you have multiple symptoms in different organs. I like to, when I talk with my patients, I like to talk about what it is, fundamentally anaphylaxis. So anaphylaxis, what it is that you're having a reaction to an allergen that has passed in your bloodstream. So when you're having reactions, your immune system is going to see the allergen everywhere it touches. So when you eat it, it's going to itch in your mouth. You're going to get a tummy ache when it reaches the stomach. But then you're going to digest it and it's going to reach the bloodstream. And the problem is when it's being distributed, then it can activate all the organs in the body all at once. And that's potentially dangerous. Historically, in the 80s, there were really not that many patients, kids in classes that had food allergies. So there was a lot of teaching efforts needed just to explain that it's a serious disease. You can't just, move the peanuts out of or take them off the drumstick and then eat it. So we really had to focus on the fact that it was severe, life-threatening. There were some doctors that didn't believe in it. There were some allergists in the 80s that did not believe in food allergy, just to give you an idea. We're not there anymore. So the message has come through. And now we're realizing that we might have gone a bit overboard, focusing on that potentially life-threatening part, because most of the time it is not going to be life-threatening. It is not even going to be severe. Anaphylaxis is just the fact that the allergens in your blood, so you're triggering multiple systems at once. And we really realized that when we started doing studies that involved challenges or introduction of the food, and the parents were stressed out, but said, okay, let's do it. And then we would go to the kid and start doing it, and then they would go berserk. And the parents would say, I really don't understand. And then they realize, well, that's probably what we keep telling them. So we realized that the message was maybe a bit too much because we weren't able to convince them that, this is fine in this context. And when we look at the quality of life of patients with questionnaires, you see that oftentimes it's taking a disproportionate aspect of their life. So I say that's about maybe 10 years ago that there was really a shift in the way we were we were addressing the question of severity and really putting in question that maybe we shouldn't focus that much on the severity part. If you have someone that doesn't believe in food allergy, then you really need to hammer down this message that is serious. But for someone that already understands, you maybe don't need to repeat it all the time, because the reality is that yes, it's there, but there's a low risk of it happening.
Okay, terrific. So let's talk about who's at risk of anaphylaxis. If I've been diagnosed with a food allergy, does that mean I'm at risk, or are there some people that can be diagnosed with a food allergy and they're not at risk of anaphylaxis? Dr. Upton, if you could maybe lean in on that question.
Great, thank you. So we do in medicine tend to treat everyone with a food allergy as having a risk of anaphylaxis because there's so many internal and external factors that can change all the time. So if on Monday my body is a certain way, on Tuesday I might be different. I may have a cold, I may be sick, I may be have just gone for a run, I may have taken certain medications that can increase my risk of reaction. And then also in terms of what I'm exposed to, I may have a certain reaction if I have a tiny bit, but I may have a different reaction if I have a large amount. So we do tend to treat everyone as if they are at risk, although we know that some people are at more risk than others. So some clear examples would be people who only have what we call oral allergy syndrome, where they're allergic to nuts in the sense that they get an itchy mouth and they get, they can also get stomach issues from eating nuts. But the reason is because they're actually allergic to tree pollen rather than a different type of allergy to nuts, which tends to give a higher chance of anaphylaxis. So we do know that there are ways that we can risk triage people, but even the people that only have the oral symptoms to nuts do have a small risk of anaphylaxis. So there are certainly people at more risk and people at less risk, but there's so many other factors that can influence the risk that we do like to have these sort of two tenets of reducing your chances of a severe reaction to food allergy, which is doing your best to avoid the food, as well as always being prepared for an allergic reaction, or an active treatment regimen of something like oral immunotherapy, as well as still having the treatment ready for an allergic reaction.
Okay, terrific. Now, we did get a question related to gastrointestinal issues and things like IBS. Is there a correlation with someone who is experiencing more gastrointestinal or symptoms like IBS to be more likely to have a food allergy? Does the evidence give us any insight on that? Dr. Upton or Dr. Bégin?
So, well, no, there's no correlation between the two.
Okay.
So
Okay.
IBS, I guess, is irritable bowel syndrome.
Yeah.
Yeah.
Yes. So then this whole around, is it possible to stratify severity of reaction or to predict who's most at risk? I mean, Dr. Upton, you talked about a number of different cofactors, but Dr. Bégin, can you step into that question? Can the medical community help people define if they're higher at risk than the next person?
So it's really the challenge of doing a talk in front of people. So you want a general message that's going to apply to everyone versus being with your patients. With my patients, I do estimate the risk, because living with a food allergy is managing a risk. Like when you're taking your car every day, you assume the risk that you might have an accident, but you do everything you need to bring that risk down, and you can live with it. So a food allergy is the same thing, and that risk is, everyone's at risk, but that risk is definitely not the same between different people. So there are different ways you can do this. So obviously the tests will help you a little bit. But you need to be careful because the number itself isn't a diagnosis. It depends on other things. There are other tests that we do in the research that we don't have access to that tells us that, this is not the same above 100 than that other patients. So we're gonna look at the history of the patient, what type of reaction they did, and how much of the allergen it took for them to react, because people tend to react generally in the same way. And that's a really good thing, because when you talk to adult patients with food allergies who've experienced a lot of reaction, they learn from them, and then it becomes much easier for them to live with the allergy because they know what to expect. They know when they get the symptoms, they know, oh, this evolves in more, I need to give myself Depi and go, oh, I know this is, we're not there, I'm fine, I don't need to treat it. And this is what I call expert patients. So the best example is actually allergists that are themselves allergic to peanut, because they have this perfect understanding of the concept of threshold, the fact that it can vary over time, but we can explain why it varied. So they usually live very well with their food allergy. And on the other opposite, you have patients that either just got their diagnosis or they've had it for a long while, but they've never reacted. You've been very careful, you never had a reaction. Paradoxically, you're actually at higher risk of having anxiety because you don't know what to expect. Sometimes people don't even know if they're really allergic or not, but no, they're not taking any risk because there's this notion that any allergy is potentially life-threatening. And sometimes they have big surprises when we do the challenges. Not necessarily that they're not allergic, but you reach 30 peanuts before they start reacting. So like Dr. Upton said, I can't tell you that because today you reacted to 30, tomorrow you're still going to be at 30, but you're not going to go from 30 peanuts to start reacting to traces. There is some ability in that.
Okay. So that's a conversation with your allergist, getting to know your allergy, getting kind of inside that to understand what your risks are. It's not necessarily like you can go to the education community and say, okay, here's how you can identify someone at risk that's in your classroom. You really need to rely on that anaphylaxis plan that the patient or the student provides to the school. Okay,
Absolutely.
let's move on to signs and symptoms. And Dr. Upton, let's go to you on this. Let's talk about what are the signs and symptoms of anaphylaxis. And then once we've talked about that, I'd also like you to talk about how that might look different in infants. Okay.
Right, thanks. Yes, so the signs and symptoms of anaphylaxis, we tend to talk about the organ system, and so we can think about the skin, so hives, swelling, itching, warmth, redness. Those would be the classic symptoms, as well as breathing symptoms where you can have coughing, wheezing, shortness of breath, chest pain or tightness, throat tightness. You can have, because of the symptoms in the throat, you can have a change in voice with the throat tightness. as well as upper respiratory symptoms, so nasal congestion, like hay fever-like symptoms, runny, itchy, watery eyes, those kinds of symptoms. And then you can also have stomach symptoms where you feel nauseated or feel like you're going to vomit, or stomach cramps, and as well as diarrhea. And then the heart symptoms or cardiovascular symptoms, where because the blood pressure can reduce, then you can feel weak or lightheaded or look paler than usual. And so those would be the main sort of classic symptoms. And then in infants, though, they can be a little bit harder to understand and harder to recognize, because an infant can be, very fussy or have a behavioral change, but a behavioral change alone, we would want to be cautious about calling, about worrying about an allergic reaction. But the infants, we are all learning about how infants present, and it can be a little bit different. Also, their normal symptoms can be difficult to assess. And so, for example, if an infant is tired, they can be, very irritable, or before they need to have a poop, they can act like they have a lot of tummy pain. And so we really do try to optimize the timing when we're trying to do diagnostic food challenges, for example, where we're trying to find out for sure is an infant allergic or not. We really do try to pick the timing very well around a child not being too hungry, not being too tired, all of these things to really minimize the interference in us judging the reaction. They can, of course, have some of those traditional symptoms that I just listed as well. I mean, if they have hives, then that's a rather straightforward symptom. But it's the stomach and the irritability that can be a little bit difficult to recognize.
Okay, so that sounds like it's a lot of things that could happen. So, when we're talking about skin symptoms, breathing symptoms, gastrointestinal, like, how do you take away this is a mild allergic reaction and I've just moved into, no, this is anaphylaxis? So I'll leave it to Dr. Upton or Dr. Bégin to lean in on that. Like, when do you kind of get beyond, okay, it's a mild itching in my mouth, to, no, this is anaphylaxis?
So one of the things that I'll just pick up on that Dr. Bégin mentioned was the idea of where did the food touch versus where did the food make it in terms of the bloodstream. And so when people have had allergy tests, they know that if we put the food or the purified, we call them extracts, the purified food on the arm or on the back, and we do that scratch test, you see that you get that itchy red bump. And so it may not be surprising that if I have a crack in my lip, or if I have chapped lips, or if I have significant eczema, that you can see that same thing if I was to eat the food. And that would be a local reaction, and it's not evidence that it's sort of gone around, through the body. So that would be one of the distinctions. Of course, at the time, nobody wants a patient to, Dr. Bégin mentioned the expert patient versus, someone that's new to this. I don't know that the medical community expects everyone to be, piecing together all of these things. And so we certainly always say that if there's any doubt, then just treat it as if it's anaphylaxis. But, isolated lip swelling where the food touched, I think many people would be confident to recognize that that's just lip swelling where the food touched.
Okay. Dr. Bégin, anything to add to that in terms of,
Yeah,
also if you could maybe address this, this idea between the difference between a panic attack, right, and anaphylaxis, because that also, it does feel like when you're in that stressful situation that there's breathing difficulty. So maybe if you can add that.
So I mean, it's very good the way that Dr. Upton just put it. So because you don't need to think about anaphylaxis as severity. See, there was no part of severity in that definition. You can have mild anaphylaxis. So the moment you have mild hives all over your body, it's considered anaphylaxis because you know that the allergens in your bloodstream. If it's mild, usually people might not give themselves epinephrine. If I see a patient at the clinic whom we're doing a food challenge with, and they get rhinitis, they get congested nose and conjunctivitis, I'm going to give the epi, even if it's one organ at that time because I know that it's the only medication that works and it's going to work right away. And I also know that if I don't do anything, it's probably going to get worse and he's going to be congested all night and have a horrible night. So giving epi, saying it's anaphylaxis doesn't necessarily mean it's severe. It's just the right way to treat it. So you want to recognize it that way. It's different. We have all these discussions about, they're not always severe. The threshold might be this or that. It's one thing to say this when you're in clinic with your allergist, when you do a challenge, and then you making that call at home. So like Dr. Upton said, everyone's not an expert. So that's what we say, in case of doubt, just give it. So there's two messages here, because there's a message of how we want you to manage anaphylaxis, but there's a message how we want you to perceive anaphylaxis. So we want you to treat it as a potentially life-threatening thing, but we want you to know that it's not really life-threatening in the vast majority of case, so you can live with it better. The panic attack is something that we see often. So when I get a call from the ER saying that we've given 6 epi and it doesn't work, usually that's a hint that it's not anaphylaxis, because anaphylaxis responds to epinephrine very, very well. The problem is if you give epinephrine and you're panicked, your heart rate is just going to go up and you're going to be panicking more. Problem is if you hyperventilate, sometimes you're going to trigger some wheezing. Some people have a tendency to hive, so it might trigger hives. But one thing I find that works well is I tell people when we're not sure and it's just itching your mouth or it's closing, I say close your mouth and try breathing through the nose. So the nose is going to heat up the air, increase moisture, so it doesn't irritate your throat as much, and you can't hyperventilate through the nose because there's just not that much air that can pass through. So it prevents you from hyperventilating. So if you close your nose, then oftentimes you realize, oh, you know what? It's not really blocking. I feel that it's tight, but the air is clearly passing fine. So right there you can relax and take your time to assess the situation. So you could still give yourself the epi if there was a reaction, because you can have both. You can have a panic attack, hyperventilate while you're having an allergic reaction, but oftentimes this will help clear it up.
Okay, great. Now, what about with an asthma flare-up, right? How do you distinguish, and Dr. Upton, if you can take this question, how do you really distinguish between anaphylaxis and what might be an asthma exacerbation?
Great, so this is a great question, and actually it's something I wanted to highlight a little bit earlier, that for people who do have food allergies and asthma, it's really, really important to control the asthma as best as possible. And so to really understand the symptoms of asthma, to recognize when asthma is out of control, to recognize that we really want asthma treated, meaning that you can run and do what you want. You don't wake up in the middle of the night with a cough. You don't need your blue puffer for relief. We really want to optimize asthma control. Because when asthma is not optimized, we can imagine that, if the airways are supposed to be all nice and big and have the air passing through very well, in asthma, what happens is that because of inflammation, like cells, as well as because they're tightened, then the air becomes hard to move through the lungs. And then if we were to add on to that an accidental exposure with food or a deliberate exposure with food in oral immunotherapy, then those airways can tighten even more. So we really want asthma very well controlled. To have isolated breathing as a symptom of an allergic reaction is not typical, but not impossible. And so in general, we would suggest that if you were feeling chest tightness and you had a known exposure to your allergen, or you had a potential accidental exposure to your allergen, in the setting of having asthma, you wouldn't be wrong to give epinephrine there, because that could be a sign that food made it through the bloodstream and is actually in the lungs. Having said that, it would be more common that if it was a food trigger that you would have had the breathing plus another sign, but you're just never wrong to use it. So if I wasn't sure if I was having an asthma attack or an allergic reaction, I would use epi and then Ventolin. So, it can be hard to tell, right? But the epinephrine will also help the lungs. So you'd be better, you know, you'd be
can't go
better to
wrong.
use epi if you're not sure. Yeah.
Okay, terrific. Okay, thank you. So now let's talk about speed of onset and then also delayed reaction. So Dr. Bégin, first off, in terms of, you know, if you are experiencing an allergic reaction, you know, is it something that happens quickly or can it be delayed?
Yeah, so it's actually quite simple. You know, it's wherever the allergen touches, you're going to get the symptoms. And the allergies, the allergy cells are full of histamines. As the moment they touch the allergen, they blow up, they release the histamine. You have the symptom right away. So you're usually going to get symptoms within minutes in your mouth. In the stomach, maybe around 15, 30 minutes. And it usually takes about 30 minutes to absorb a food. So usually you're going to start getting the other symptoms between 30 minutes and 60 minutes after ingesting the food. After 60 minutes, usually if you've eaten a food, you're going to reach a plateau of that concentration in your bloodstream. That's going to stay there for the next 2 to 3 hours. So if you haven't reacted within the hour, usually you're not going to react later. So that's why when we do a food challenge at the clinic, we always keep the patients for 1 hour. And 3 to 4 hours after that, then if you look in the blood, the allergen, the food allergen goes down. It's been processed. It's not there anymore. So if someone's having a reaction in the morning and they tell you, well, last night, we can stop right there. Last night has nothing to do with it. Now, there's one exception, is the cofactors, because one way the cofactors can work is they can interfere with the barrier in the stomach, allowing you to absorb the food faster. So assume that you just had the food, you've reached that plateau after 1 hour, so you're 2 hours in after eating the food, and then you go for a run. There's still a lot of food in your stomach, and then all of a sudden you absorb it. So now you've increased the amount of your bloodstream. Maybe you've just reached the threshold that makes you react. So when we're talking about reactions that occurred 2 to 3 hours after the food, usually it's because there's a cofactor that's involved that wasn't there at the beginning, and then it's adding it that made you react. Another thing we hear a lot about is biphasic reactions. So people are worried about, you know, oh, I treated a reaction, but is it going to come back? And there's a lot of confusion there, because the true biphasic reaction is something we mostly see with asthma. It's that the allergy cells, when they blow up, they start producing other mediators that will have their peak effect 8 hours later. So sometimes you do the skin test on patients. The skin test is positive, it goes away after 30 minutes, but then at night it starts itching again, and then the next day you see a bump again. That's a late phase reaction, so it's a biphasic reaction. So this occurs 8 hours after, and you usually see that with asthma. With food allergy, it's extremely rare. But then people say, I had a biphasic reaction. So what are they talking about? So usually what people are talking about with biphasic reaction is that they've had the food, they started reacting, they treated themselves with epi, and everything went fine. And then 30 minutes later, the epi's not working anymore, and then you have new symptoms that are coming. So you say, oh, I had 2 phases, but it's really the same reaction. It's just that the food, you treated so early, it keeps being absorbed, and now you've reached your plateau, your high end. So usually these reactions will respond very well to the second dose, and then you'll be fine, which is different that biphasic reaction. And usually, like I said, it's 8 hours later. But if you go to the ER, they only keep you for 3 to 4 hours. So that's telling you that that reaction 8 hours later is extremely rare. It's not even something serious enough for the ER doctors to keep you, unless you have some other risk factors, like you've had that in the past, you're taking medications that increase your risk of asthma or of epinephrine not responding, or you had a severe reaction and there was a delay in the use of epinephrine, then they'll keep you for the night usually. But otherwise, it's extremely rare.
Okay. One last question before. Oh, sorry. Go ahead, Julia.
Sorry, I might build on that just a time, just because of the news articles and so I absolutely totally agree with Dr. Bégin. I'll just add, just because of the recent news articles on alpha-gal. So, you know, and we don't want to spend too much time, but just that there are some very rare causes of delayed food anaphylaxis, one of them being to mammalian meat from one part of the meat. It's very rare. It would take us a little bit of time to chat about it, but just, it's potentially an increasing cause in Canada just because of probably global warming, and it's linked to a tick that used to be mostly in the southern states that's creeping its way up here. And then the one other one is that we do see it being a little later, although still within the time frame that Dr. Bégin discussed, but we can see a bit later with when we use modified foods like baked milk or baked egg. There's emerging literature that the onset of reaction is a bit later, and I think it's exactly for the reasons that Dr. Bégin discussed, that instead of drinking the milk directly and then seeing that food quite quickly, there seems to be a longer time in the digestion process to see baked milk or baked egg, meaning milk or egg that has been incorporated into a flour type product, you know, like a wheat muffin or pancake or that kind of thing. We can see reactions a little later than we're used to.
Okay.
Yeah, and just the wheat itself also is kind of an exception. Wheat, you can have the reaction up to 2 hours later, and it's exactly the protein stuck in the gluten, and it takes time for it to be processed and released.
So typically pretty quick, but in some situations it can be up to 1 to 2 hours, and in the case of alpha-gal, it's more like 8 hours.
Yeah.
Okay.
And except for the diarrhea. The diarrhea can be 4 to 6 hours later, and that's logical. It's the time that it reaches the organ.
Okay,
Yes.
terrific. Okay, so let's move on to treating anaphylaxis. Let's go to you, Dr. Bégin. I think we actually have the 5 steps of that we've got listed in many of our patient materials that I'll put up, and then if you can talk about you know, your approach on treating anaphylaxis.
Yeah, so the the first step is clearly the most important. We keep talking about it, but it's because it's important. It's giving epinephrine. So epinephrine, what it does, and you're really, it's a synonym of adrenaline. It's just when it's a medication, we call it epinephrine. So adrenaline, it raises your blood pressure, it opens up your lungs. So all the opposite of anaphylaxis. So it's great. But the most important thing is that there's a receptor for adrenaline on your allergy cells, and it turns them off. So when you start reacting, you want to give epi as fast as possible, because those allergy cells that have already reacted, well, it's too late. You can't put the histamine back in. But it's a chain reaction. It's going to start activating all the other ones, and the other ones are going to start seeing the allergen because it's getting distributed throughout your body. So you want to give the epi as fast as possible so it can reach all those mast cells that haven't blown up yet and turn them off. So it's, you know, when you're learning a CPR, they say, okay, if you're alone, the first thing you do is call 911 and then start doing your CPR. Here's the reverse. It's so important to act fast that we want you to give the epi first. Obviously, if there's 2 people, you have one person call 911 while the other is giving the epi. But if you have to choose because you're alone, epi first. The third step is just, if it didn't work in 5 minutes, you can give it. So often that's when can I give the second one? It's 5 minutes. The peak of action, usually you should see it by 15 minutes. So it's not that it had its full effect, but if you're not improving, you should start seeing something within 5 minutes. So just give the other one. Then step 4 is going to the ER, and that's something that's really important. You know, they're by steps like this. You're going to the ER because you think the reaction is relatively severe or has a potential of becoming severe. I've had a lot of patients tell me, oh, I didn't give myself the epi because it wasn't severe enough for me to go to the ER, or I didn't want to go to the ER. These are 2 different things in your thinking process. You know, and I tell these patients, you know, if you're gonna not give yourself the epi because you don't want to go to the ER, I'd rather you give the epi and then not go to the ER. I'm not saying don't go to the ER, but I'm saying separate the two process, because you're not going to the ER because of the epi. The epi is totally not dangerous. Epi in the muscle is not the same thing as epi in the heart, like in Pulp Fiction, or in the veins when we're doing advanced CPR. It doesn't have, the only side effect is the same thing. And when you're in secondary 4 presenting in front of a class, you're gonna get a little bit of shaking, your voice gonna be trembling a little bit, and your heart's gonna race, and that's it. So it's not a big deal. But it's a big misconception, even in the medical community. So oftentimes we're talking with nurses and doctors in the ER, in the wards, and they all think that you need to be put in a scope if you give epi, because we're the only ones that give it in the muscle. Everyone else gives it directly in the veins, and then it goes to the heart. So then it can be tricky. But you really need to reassure everyone you know that epi is not dangerous. You're never wrong to give it. So if you have a reaction, the tricky thing is that you're not necessarily going to know whether it's a severe or mild reaction if you're at the beginning and symptoms are mild. So it's better to go to the ER, because if it does get worse, then you're already at the best place. We have some patients that, you know, those expert patients that have had multiple reactions, and they know themselves. They tell you, you know, I know I don't have to go to the ER, and I'm fine with it because they're all adults and they can make their own decisions, for one. And it's true, they're expert. They know better than all the doctors or the other people they talk to. But most people don't have multiple reactions because they've been good in avoiding the food, so you don't know. So so it's always safer to go to the ER. And the last thing, call an emergency contact. So a parent here. This is geared for pediatrics, but this is quite obvious. But for the older kids and adults, it's extremely important. Let someone know you're reacting. So if you look at people that died from anaphylaxis, there are usually some things that are always there. So one of them is the asthma that was out of control, like Dr. Upton mentioned, because the lungs were already ticklish, so you just add on top of that. The other is that they failed usually to give the epi fast enough. But the third thing is that they isolate themselves. As adults, you know, small kids are always going to go bug the parent or the whatever, the caretaker. But adults, we don't want to bother anyone. So you're going to start reacting. What is the person going to do? They're going to go in the washroom, not tell everyone, and start taking the Benadryl by themselves because they don't have their epi with them. But then when something bad happens, there's no one seeing it. So I tell my adult patient and teenagers, the moment you react, you say it. And you say it, you know, jokingly. Imagine someone at the suburbs, oh, is there peanut in there? Well, if I lie down on the floor, well, my epi's there, ha 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 ha, it's funny, and that's it. No one cares. But if it does happen, at least you've told them, and they know what to do. So just take the habit of doing that.
Now, I heard you say the word Benadryl, okay? And I don't see it in the 5 emergency steps.
Oh
We get
yeah.
this question so many times. What's the role of Benadryl? What's the
So
role
there's
of Benadryl?
So
Okay.
there's none. So first of all, Benadryl versus other antihistamine, there's no reason to give Benadryl. So in the world, the share of Benadryl for antihistamine is about 8%. In Quebec, we're at 25%.
Wow.
So they've been really good with their drill. But there's no reason for it because it only has more side effect. It's not more effective. It doesn't act faster than the other antihistamines. And then the other antihistamines, okay, they're better than the Benadryl, but you know, are they good? Well, the thing is, they're going to start acting before 20 to 30 minutes, and even then, they only have 20% of their effect. It takes 2 full hours for them to have their full effect. So if someone takes Reactin and 5 minutes later tells us, oh, I feel better, it's not the Reactin. It was just due to get better because, like we said earlier, most reactions are mild. So, but people think it's a reacting because food allergy is supposed to be bad. So what we worry about is that people will give it. If you put it the option of giving people are so afraid of giving the epi that the moment you give them a way out, they'll take it. But it's not a good medication. So it's not really the fact that it's going to mask anything because it's not going to work. So it's not going to mask anything. It's just that it's allowing people not to give the epi, and that's a really bad thing to do because you don't want to delay. And epi is not dangerous. If it was a pill, people would take epi all the time and they'd realize it worked and they'd live happy lives. But it's not. People are worried. They're not using it.
Oh, but are some people not using these antihistamines though in this situation to treat the itch? right? Like my child is uncomfortable. I just want that one table or teaspoon of Benadryl seems to really settle them down. Like
Yeah, I
that's
mean,
what I think
that's
we're
fine.
fighting against.
It's
Yeah,
for the itch. So I wouldn't give the epi. I would give the Arius or Claritin in syrup, or the fast melts with reactants. So I would give those. But just know that you're giving it for the itch. You're not giving it to treat anaphylaxis.
right,
But if it's itching all over from head to toe, I mean, it's not going to do anything. And even if you have only one system, I would give epi right away because it's the only thing that will work
right.
fast, will be effective.
Right. Okay. So listen, we had a question come in that I'd like to actually insert right now because I really think it kind of helps substantiate this point and the challenge that parents have. So, this is a mother of an 18-year-old baby that has allergies to dairy, egg, wheat, rye, and tree nuts. And she's never given the epi, and her baby has had reactions with hives and vomits, but she's given antihistamines and he got better in the 15 to 20 minutes, no breathing systems. So, would you give epi instead of waiting for an improvement with an antihistamine?
Well, in retrospect, we can't say that she was wrong because it
It
turned out
worked,
fine. So,
right?
so the reality is that 95% of the time you do nothing, and you'll be okay. And we were in San Francisco at an allergy conference, 6 allergists going to Chinatowns having dumplings, and one of us was allergic to shrimp. So obviously he said, "Oh, well, don't mind me. I'll just won't eat the ones with shrimp." And then obviously at some point, I said, where is he? So he was gone in the bathroom. So because he didn't have epi, he didn't have antihistamines, so we're just throwing cold water in his face, telling no one. And then what did we do? Well, we just sat it out and remained calm, and that was it. He should have used the epi. It would have worked. It wouldn't, but it turned out fine.
Right.
Most of the time, it will turn out fine anyway. It's probably not due to your antihistamine. Doesn't mean that you shouldn't use it next time, because if it's a worse reaction, the problem is you're waiting and you're losing time. You
Right.
can't really ever know what
Right.
is
So
going to
what you're
happen.
saying is that 15 to 20 minutes, it wasn't about the antihistamine. It was just that
Definitely
the
not,
reaction subsided. Yeah.
for sure.
Okay. Okay. So the other thing too is some people, again, they find Benadryl works much faster than Reactant. I think this is what it's just that it's really hard for us to get our heads around this idea that it wasn't the medication, the antihistamine we gave that subsided things. It was just how the reaction proceeded, correct?
Yes, and it has more side effects also. So you have the feeling that it does something because the drowsiness is going to kick in quite fast.
Right.
So you feel it's doing something. It corresponds to the moment your reaction got better.
Well, I know that when my children were young and I gave them Benadryl, it did make them a bit tired, and that felt like a calmer situation.
Yeah.
And in fact, I've heard some allergists talk about it as being you know, a serving your baby a cocktail. So, anyways, I think the message is pretty clear. Antihistamines don't have a role in
And and
anaphylaxis.
the other thing just about this, because we're on the topic, it induces drowsiness, but it doesn't induce sleep. So it's, if you give it to help someone sleep, it's a really bad idea because it's the same type of sleep you get with alcohol. It prevents you from
Okay.
going into deep sleep. So it's a
Okay.
really bad idea. It makes you worse the next day, more
Okay.
tired.
Okay, I want to move into the fact or fiction section because there's some really good questions that came up on this. So what I'm going to do is I'm going to give you a statement, and I'm going to ask one of you to determine is it fact or fiction, and give us a quick explanation. So the first one to you, Dr. Upton: food allergic reactions get worse with each exposure. Fact or fiction?
So fiction, because it's not universally true. And so we've actually chatted about this before, that it's very interesting. The way your body perceives an allergen very much depends on the route of exposure and the frequency of exposure. And so we know now, for example, in oral immunotherapy, that giving the food each and every day, we can actually create a situation where that person can eat more and more and more of the food, and in some of the studies actually have a less and less and less reaction. So And yet we also know that, for example, somebody who gets intravenous antibiotics just every once in a while, but repeatedly, again and again, will be at a higher risk of being allergic to that antibiotic than somebody who's never had it. So there's this, it's sort of based in a truth in the sense that we believe that you have to have seen the allergen previously in order to have a reaction. But it is very nuanced in the sense of what we call the route, like what part of your body did you see it through? Did you see it through the skin? Did you see it through the mouth? Did you see it intravenously? As well as the frequency in which you see it. So as a global statement, it's fiction.
Okay, perfect. Okay, thank you, Dr. Upton. Dr. Bégin, this one to you. Smelling your allergen or being in the same room as your allergen can trigger anaphylaxis.
So by definition, you're not smelling protein, you're smelling aromas. Which are benzene rings, which is not the allergen, basically. So the smell has nothing to do with it. So in order to react to food that's become airborne, well, it has to either be cooked, like you'll see that with fish, when sometimes you'll get the droplets and then you breathe that in, or when you're using flour, and then you breathe it in. So this is the type of things, but it's never going to be anaphylaxis because it will never enter your bloodstream. What you'll get is a reaction everywhere it touches. So it's going to be like pollen or cat. You're breathing it. So you're going to get a severe conjunctivitis, rhinitis, or severe asthma attack. Doesn't mean it's not serious. People die from asthma. So asthma can be very serious, but it's not anaphylaxis per se. The thing is that people make unconscious connection. So if you had a severe reaction with a food, usually you will remember the taste of the food and your body will give you a signal to protect you. So you'll get an aversion and it'll sometimes start itching. They did a study where they put peanut butter on a piece of paper and they held it 10 centimeter to the face of patients for like 20 minutes. And there was peanut butter and fake peanut butter. I don't know what they use. And then those were all patients with IgE above 100 to peanut. And none of them had reactions. They did the breathing test. There was absolutely no symptoms. However, there was 20% who said, it's tingling on my tongue. That was it. And they were right. So it was really with the peanuts. So, but that's really it.
Okay.
So there's really no issue if you're entering a room where there's the food you're allergic to. What you don't want is indirectly bringing it inside your body.
Okay, thank you. This next one to you, Dr. Upton. Touching your allergen can trigger anaphylaxis.
So again, as a global statement, I'll say that is fiction. But they always need a caveat, and I'm sorry for that. But what we worry about is that touching the allergen and then we touch somewhere that it does get better absorbed. And so touching the allergen and then touching the mouth, for example, could trigger anaphylaxis, but that amount would be highly unlikely. Now there are people who are extremely allergic, but they are infrequent. The other piece that could happen is if, for example, I had a cut on my hand and I was to touch the allergen. Again, it gives another way for it to be absorbed into the body. But again, we know that that's very unlikely because on a routine basis, allergists put drops of the foods, on the skin or on the back, and then scratch them with a little lancet. And the chances of having an allergic reaction to that is exceedingly small, less than about 1 in 2 million. So as a global statement, it's fiction. But we really encourage people to wash their hands.
Right.
I mean, it really is a very important way to reduce the chances of you seeing that allergen into your body.
Perfect. Okay. Now this one to you, Dr. Bégin. Fact or fiction? A trace amount of an allergen triggers anaphylaxis.
So that's a blank statement like this is definitely a fiction. So you have a spectrum of patients that are allergic, and you have patients that we say they're sensitized. This is a term that we invented in allergy because we have patients with positive skin tests. So basically it tells you, okay, they have antibodies against the food. They could react to the food, but then you do the challenge and you reach 50 peanuts and they don't react. So clearly these people can eat traces without problem. So the idea is that you have a certain amount of antibody which is going to arm your allergy cells, and then for tons of different other reasons, you have a certain threshold to which you react. And for these patients, you can imagine the threshold is just so high that by eating 50 peanuts they can't even trigger. They need to give it IV to get a reaction. But on the other end of the spectrum, you have those patients who are severely allergic, who will react to traces. So if you look at patients in general, and with actual food allergy that was confirmed by a food challenge, it's definitely less than 5% who will react to traces. The problem is I can't say who unless I do a challenge. So the instructions for school, for everyone, is just avoid traces.
Right. So it might be better to say a trace amount of an allergen can trigger anaphylaxis in some.
Right.
In some, exactly. So not a blanket statement. There's a practice that's developing more and more, is that people are asking their allergists for a food challenge, not because they want to know if they're allergic or not, just to know where's my threshold, so I can take an informed decision with regards to my risk.
Okay. Next one to you, Dr. Upton. Going through puberty or being a teenager increases your risk of severe reaction. Fact or fiction? You're always hard, right? I can't. It's not always that clear to put it in the fact or fiction bucket.
So I'll tell you what, I'll give you the answer first, and then we can all decide fact or fiction. So being a teen is a risk for allergic reactions, and this may be more of a behavioral issue, although we're not totally sure if it's a physiological issue as well. That's why I want to be cautious about blaming the puberty. But from a behavioral point of view, as Dr. Bégin mentioned earlier, when you're a little kid, you're very much under the domain of the parents. And then as a teenager, you may be reluctant to tell people your allergies. You may be reluctant to ask in that restaurant, does this contain this? I need to avoid this, or to carry the epinephrine auto-injector. And so for a lot of behavioral reasons, you may be at more risk. There's also whether your family is still, helping and prompting you with your asthma control. Are you taking a puffer routinely? Are you recognizing signs and symptoms of asthma? So from a lifestyle point of view, and from an at-risk time period, we do pay extra attention to the teens. So I guess I'm gonna maybe say fact on that one. But it's not a universal fact. But we do have to recognize that teenagers are special for many reasons, and we just need to be extra cautious that they really understand that they have a lot of control over minimizing this risk with controlling the asthma and being knowledgeable and prepared for reactions.
Okay.
It's a tricky period when you're transferring the responsibility from the parent to the child, because in adults, they have lots of reactions also, but it's not necessarily a bad thing. Some of them, they take risks, they calculate risk, and they don't mind those reactions. And it's an informed decision, and they wouldn't go. They do it regularly, and they know their threshold. They know the symptoms. So in the end, I wouldn't qualify this as being necessarily a problem. They're just comfortable with their allergy.
Okay.
But you need to get to that point.
Right, right. You need to learn about your own food allergy before you start to kind of experiment. Right. Yes. Okay. So one more fact or fiction question, and then I'm going to ask you for some closing comments. So there's a few questions that came in about IgE blood work, and that, off the charts levels in terms of the numbers that have come back through these IgE tests. And the fact or fiction is, does the IgE blood test indicate whether a reaction will be more severe? Okay, so is having a high IgE blood test synonymous with a higher severity of reaction?
So fiction, it's not synonymous, because you have patients with IgE above 100 that are not that allergic, and usually above 100 they are allergic, but the threshold is not necessarily that low. What you need to know is that the absolute number itself is not everything. The more IgE your body produces, the less sensitive your allergy cells become to it. So if you take a population, yes, the ones that are above 100, they're more allergic than the ones that are below 10. and which are more allergic to the ones that are below 1. But on an individual level, you can have someone with 0.1 IgE against peanut. If his total IgE is very low, also undetectable, he might be anaphylactic to the food, while someone is above 100 and can actually tolerate the whole peanut without reacting.
Okay. Okay. So again, it's getting to know your allergy, working with your allergist. This is one piece of the puzzle. Let's not make any statements that of concrete nature that says this is an indicator of severity of reaction. Okay, terrific. Okay, I'm going to ask both of you if you would leave our audience with some closing comments. I did want to, to the viewing audience, there were some questions that came in around early introduction and infant anaphylaxis, and we had a conversation beforehand that if we didn't have time to get to those, that we would consider another webinar on that topic. So for those of you who are interested in that part, we will be back to you and let you know about our plans later in the year to tackle that topic. So with the last few minutes we have available, Dr. Upton, first to you. Let's give our audience a couple of closing comments on this topic around demystifying anaphylaxis. Know it, treat it. What would you like to say?
Well, thank you for letting me go first, because I might trump Dr. I'm sure he has the same thoughts, but I think he said it very well at the beginning, that one of the things we're really trying to do now is to separate anaphylaxis from fatality. That yes, there is a risk, but it is small, and really we can be someone that is at risk of anaphylaxis, and we can manage that risk, and we can know it and treat it. And so that, I think, would be the main thing, that the fatality risk is very, very low. We need to do our best to prevent anaphylaxis and manage it. And then the second one would be that I try hard with my patients to reduce the hesitancy to use epinephrine, because it really is a miraculous medication. And when you've seen a severe allergic reaction and you see the speed of the response to intramuscular epinephrine, and then you know that you have that in your hand, one of the things I often say is, if 20 doctors were around you and you were having an allergic reaction, they would want you to take the epinephrine auto-injector. You have that medication that every emergency doctor would be, or every allergist, everybody would be wanting you to take, and you have that in your control. So I hope that people can feel that that's a good medication to have. It's unfortunate it's an injection, but hopefully
that'll change. I mean, there is some things on the pipeline, but yeah. All right, great. Thanks, Dr. Upton. Now, Dr. Bégin, over to you.
Yeah, I mean, I'd say epi is not dangerous. So that's really the message that needs to come out, and which you need to communicate to people around you also. So epi is not dangerous. Second, asthma control. So when you look at the fatality, we talk about anaphylactic shock. Shock means your blood pressure went down. When you look at people that died from anaphylaxis, those rare cases, only 10% had shock. 90% died because of the asthma attack. So the thing everyone has in common in those fatality is that they had uncontrolled asthma. Like we mentioned before, it's rare that someone would only have asthma symptoms as a reaction, but if that happens, it means that the lungs are already activated. So don't hesitate to use epi. It's not dangerous. Make sure you control the asthma and let people know if you're having a reaction.
Awesome. Well, listen, thank you very much for taking the time to share your expertise with us today. I imagine our viewing audience got a lot of really great insights. And so I'm going to ask you to turn off your webcams, and I've just got a couple of closing comments that I would like to leave our audience with. So first off, there's three things. Know that as per usual, you'll get a short survey through GoToWebinar immediately after this. It'll come up on your screen. You'll also receive a survey in the email in the next hour. Please take a moment to complete it, because your feedback is really crucial in helping us improve our future webinars and also to better understand what additional questions or comments you will have. Also in our handout section, take a look, because we've got some new things there. We've got our care guide, our newest resource called Caring for a Child with Food Allergy. The original intent of this resource was really for caregivers. It does include signs and symptoms of an allergic reaction as well as the 5 emergency step. It's a very visual piece. It's one that you want to have on hand and share with others. It's 6 more days in Food Allergy Awareness Month for the month of May, and we'd really like to encourage you to all help educate and empower others through our Know It, Treat It campaign. There's a few simple things you can do. You can significantly broaden our reach so more people can learn the facts on anaphylaxis. Go to foodallergycanada.ca/FAM, FAAM, where you'll find shareable GIFs on anaphylaxis that you can download, share. If you're on Facebook, Twitter, or Instagram, you could repost, retweet, share, and like our posts on anaphylaxis. We've got new content happening every day. One final way to get involved is by sharing your own personal reaction story and how you would know and treat anaphylaxis. We have created some personalized GIFs for you, and we'll share your story through our Know It, Treat It gallery on our site. Sharing real stories is a powerful way to learn about, learn and support others. So, link to our Know It, Treat It campaign on our website, and please take a look at the handouts in the section of the webinar. So today's webinar, I'd like to really thank our supporters. This has been supported by the Walter and Maria Schroeder Foundation, the Sean Delaney Memorial Golf Classic, EpiPen, and the Peanut Bureau of Canada. It's also made possible from the donations of viewers like you. Please help continue this type of programming and consider a donation today. You can visit foodallergycanada.ca/donate to learn more about the impact of your donations. Thank you for your participation in today's webinar. You can view a recording of this webinar at foodallergycanada.ca shortly. Please also share it with others who you feel may benefit from this content. This now concludes our webinar.